Great. Thank you so much, Adrian, for that introduction. So let's get started here. We're talking about the heart of the matter. This is going to be cardiometabolic testing in clinical practice. And I am Dr. Malkowski, staff doctor with Doctor's Data Clinical Education. Let's begin. Today, we're going to focus on cardiovascular disease, and this is a very important topic in clinical practice. This applies to every single patient that walks into your door, as cardiovascular disease is the leading cause of death. This is the leading cause of death worldwide. Second, it would be cancer, and in the United States, but also in other countries across the globe. So, this is important with regards to health and humanity and outcomes. With regards to cardiovascular disease, there's a saying that goes, what is the first sign of heart attack? Is it numbness, tingling? Is it pain in the left arm? Is it nausea? Is it chest pain? Actually, it's heart attack. And it used to say the first sign of death, the first sign of heart disease is death. And that's because this is a significant silent killer. So your patients aren't going to necessarily walk into your office and say, I have dyslipidemia, I feel unwell. They don't. They feel normal. They feel healthy. They feel within normal limits. So it's really upon us as functional medicine providers to educate ourselves on this topic and to educate our patients as well on cardiovascular disease and the associated biomarkers. Within this category today, we're also going to be talking about metabolic syndrome. Metabolic syndrome is a risk factor for cardiovascular disease, and these are intricately linked. The other systems that we will link today are going to be renal, so the kidneys, and that is intricately linked to cardiovascular disease with regards to hypertension and blood pressure. That's an important biomarker. And the other system is going to be the liver. So liver health is intricately linked when we're talking about lipid metabolism, cardiovascular disease, and metabolic syndrome. This is the year 2022. And considering that cardiovascular disease is a preventable lifestyle disease with a significant nutritional component, it is sad that we're still talking about this and we're still addressing this as the leading cause of death. Early detection and reduction of risk factors is very important for cardiovascular disease. We want to address individuals right at the beginning of pathogenesis. With regards to hypertension, we're going to talk about the biomarkers today. Really, we want to keep individuals that 120 over 80. That's going to be what we're looking at. We don't want people to go up to 130 over 85 or above, because once with this pathogenesis, once it goes severe, it is more difficult to treat, and you have to have significant factors and address it differently. So really, we want to talk about early detection, reduction. We want to talk about identifying these individuals early on, and the testing that we're talking about today is really integral to that factor. Now, cardiovascular disease is related to health. It's related to metabolic syndrome. It's related to diet, lifestyle, nutrition, environmental exposures. Lead is chief among them. There's a lot of studies about that. The other thing that we're finding now is the dysbiosis, microbiome dysbiosis. So the gut-heart axis is implicated in cardiovascular disease. There's some microbiome signatures that can be associated there. The other consideration is individuals with diagnoses of IBS. There's a pathogenesis in that individuals that are diagnosed with IBS and individuals with intestinal permeability lack nutritional absorption, proper nutrient absorption that could potentially lead to nutrient deficiencies, especially with magnesium and minerals, and that can potentially contribute to the pathogenesis of cardiovascular disease. So this isn't one system. This is something that affects the totality of human health. Unfortunately, new research has also showed that plastics play a role. So there was a study recently that microplastic, nanoplastics, these are the very tiny plastics. When individuals had these plastics in the carotid plaque, they were 4.5 times more likely to suffer myocardial infarction, stroke, or even death. So this is a significant finding. We're finding BPA increases cardiovascular mortality. That's bisphenol A. That's basically soft plastic. So that's water bottles, that's baby bottles. This is very detrimental to human health. Continuing on, we're going to talk about lipids, and lipids are made in the liver. We're going to talk about cardiovascular health. We're going to talk about metabolism, and crucial among that is an organ that really doesn't get the recognition it deserves. And that organ, you guessed it, is the liver. Now, how many people, what percentage of Americans have fatty liver? Could we get a little guess in the chat? What do we think? Is it going to be 10% of Americans have fatty liver, 20% of Americans, 30%, 50%, 45%, 60%? Okay, good. We're seeing some guesses between 80, 30, 60, 75, 30. Good. So actually, at least 50, the guess right now is 45%. Excuse me, the data right now says 45%, 80 to 90, that would be horrible. So 45% of Americans have fatty liver. The liver is a very important organ. It weighs about 2 pounds and it can hold up, half a pound of fat. That's important because we do not want fat in our liver. Now, we're going to talk about something that used to be called non-alcoholic fatty liver disease. Have you seen this nomenclature change? The American Association for the Study of Liver Diseases decided that non-alcoholic fatty liver disease does not fit what we're seeing today in Americans. Historically, fatty liver was really reserved for strict alcoholics. In the past 25 years, the past 45 years, we've really seen a change because sugar and ethanol are metabolized the same in the liver, and that pathogenesis leads to fatty liver. So previously, this would be reserved for strict alcoholics who were really damaging their liver with excess alcohol, leading to fatty liver. Over the past 45 years, we have seen a shift in that we're metabolically damaging our liver, largely due to sugar and fructose. And so the nomenclature used to be called fatty liver from alcohol, or you'd have non-alcoholic fatty liver disease, which is a really small percentage of the population. But now, as we see, 45% of Americans have fatty liver. So the new name for non-alcoholic is going to be metabolic dysfunction associated steatic liver dysfunction. And that's basically that's basically metabolic induced liver disease. That makes sense. This name is appropriate. So I want everybody to be aware of this nomenclature change. Additionally, I will just mention here that in the last 45 years, ALT used to be 25 at the higher end, and now we're seeing it go up to 40 at the higher end. So we've had this shift in our understanding of what's considered normal, what's considered within normal limits with regards to liver health, and that more individuals actually have unhealthy livers, but we're thinking that's within normal limits. So this is really important to pay attention to for our patients. Now, with regards to cardiovascular disease, the criteria for this metabolic dysfunction associated fatty liver disease is that these individuals will have 1 or 5 of these criteria. So pay attention to these criteria as we go through the cases later. The first criteria is a BMI of greater or equal to 25. So BMI is not the best marker. It really works with regards to public health. It's not the best mark for individual health. Maybe we should do height over waist circumference, but that's fine. It's just showing us that individuals of a certain BMI generally fall under this category of excess visceral adiposity and excess liver fat. The second consideration is going to be fasting serum glucose of greater than 100 or hemoglobin A1C greater than 5.7, diagnosis of type 2 diabetes, or treatment for diabetes mellitus. So any one of those is the second criteria. The third criteria is going to be hypertension. Now, look, this is 130 over 85. Remember what I said previously? We really want to keep it 120 over 80, but 130 over 85 is the criteria here, or if the individual is already on antihypertensive treatment. The other consideration would be plasma triglycerides greater than 150 and lipid lowering treatment. So if that's already being addressed, they tick that box. Lastly, the criteria would be a low plasma HDL of less than 40. We will look at some reports today. We will look at less than 60. That will be our criteria. 60 and below is too low. So they're saying 40 and below is too low. So fairly easy for an individual to fall under the category because all they need is one of these 5 to have that metabolic associated liver dysfunction. A little note here I will mention, we are seeing a resurgence in this ideology around fasting, and that fasting is a panacea for human health. Now, that might not be true. We should evaluate that data, especially since many of those studies were done in murine models. They were done in mouse. And maybe those times, those fasting times that people are trying to target, 16 hours, 24 hours, might not necessarily interact with our physiology exactly as they did in those models. I will say that this is a good fasting plays a role with regards to fatty liver. So fasting definitely plays a role in addressing that excess. Like we said, 1/2 pound of fat can accumulate on the liver, and decreasing that. Fasting does have a therapeutic role there, a good role there. Obviously, we're going to address these biomarkers. We're going to address lifestyle, diets, exercise, all that as well. All right. So, what we're talking about today is metabolic syndrome. Now, greater than 1/3 of the world's adult population is now classified as overweight or obese, and at least a quarter of those meets the criteria for metabolic syndrome. Metabolic syndrome is going to be similar to what we discussed: abdominal obesity, dyslipidemia, hyperglycemia, and hypertension. Now, according to the CDC, 41% of adult Americans are overweight. Now, this data is from 2017. I can guarantee you that it's a higher number today. This is pre-pandemic, and food has only gotten worse since 2017. So this is a higher number. Unfortunately, this is not a pediatric talk, but what we're talking about today really does apply to pediatric populations as well. As we see, unfortunately, children are suffering from obesity at phenomenal rates. Metabolic syndrome is linked to lifestyle factors such as obesity, physical inactivity, and unfortunately, a standard American diet, which is high in ultra processed foods and added sugar. Fructose has really contributed to this. The ubiquitous amount of fructose that we consume on a daily basis, and that's really going to be large sugary drinks such as pop, coffee, sugar coffee drinks, things like that. Obviously, processed food, and then some of the oils that we're consuming are playing a role as well. Um, Additional factors are going to be genetics, insulin resistance, which is integral to this, and hormonal balances, which is also integral to this. We can't really separate hormonal balances from what we're talking about today because testosterone, estrogen, all of this is linked to cardiovascular health, visceral adiposity. And then remember at the beginning, we even talked about plastic exposure, tie in there as well. So the important consideration is early diagnosis and management of metabolic syndrome. Again, we want to catch these individuals early. This is imperative to reducing the risk of complications that are serious: heart disease, stroke, diabetes. This is a real consideration for our patients. So how can we, as functional medicine providers, how can we help our patients? We need to move beyond simply evaluating total cholesterol, LDL, and HDL. Those three markers are great, but we need more information. We need to talk about oxidized LDL, small dense LDL, non-HDL, and apolipoprotein B. Like I said, we're going to move beyond those traditional values, and we're going to look at these markers that are specific regarding cardiovascular disease. Oxidized LDL is a very important marker that we're going to include. You could measure this independently on its own because it is an independent risk factor for cardiovascular disease, and you could include it in the profile. We're going to look at small dense LDL cholesterol. Not all cholesterols are the same. So when we're measuring the traditional LDL cholesterol, that doesn't really provide us with a great amount of information because some of those LDL particles are large buoyant. Those large buoyant LDL particles are cardiovascular neutral, so they don't play a role. The ones that play a role are going to be the small, dense LDL cholesterol due to their size and weight. Their size and weight enables them to propensity to atherosclerosis because they are tiny and they are heavy and they can just get right in the endothelium there and contribute to atherosclerosis. Same thing with oxidized LDL. The oxidized LDL itself is the one that contributes to atherosclerosis. It's a significant marker for that pathogenesis. The next marker we're going to talk about is lipoprotein A. I'm sure you've heard of this. Lipoprotein A is largely genetic. The good thing about this is once you measure this biomarker, it will stay relatively the same for an individual's lifetime, and that's good information to have. Lipoprotein A is unique to the other markers in the way that it behaves, but also in the fact that it's largely due to genetics. So when we're talking about lifestyle and diet and pharmaceutical, nutraceutical modification, lipoprotein A doesn't necessarily respond to those. The other consideration about lipoprotein A is that it works different than the others. The other lipids have fairly similar mechanism of action. Lipoprotein A is unique in that it basically impedes from fibrinolysis. So what happens is your body is constantly making clots and degrading clots. Lipoprotein A, in individuals with lipoprotein A, they do not degrade clots appropriately. So their risk of clots is extremely high. The next piece of information we will look at is apolipoprotein A1 and apolipoprotein B100. I'm sure you've been hearing about apolipoprotein B100. Thought leaders in the functional medicine field are putting forth this biomarker as potentially one of the most important biomarkers with regards to cardiovascular disease. So we will see that is an important biomarker because it tells you about the direct number of lipoprotein particles, and that direct assessment of that particle number can help to determine what is occurring with regards to with your lipids. We will also talk about Glycomark. Glycomark is a great marker with regards to glucose metabolism because glucose metabolism and insulin are intricately linked to this system. We will also talk about the adipokines. So the adipokines are hormones housed in the fat. Remember, fat is not biologically inert. Fat is a endocrine organ system that communicates to physiology. Chief among that with regards to cardiovascular disease is going to be leptin and adiponectin. And we'll see that individuals on the metabolic syndrome with cardiovascular disease considerations tend to be leptin resistant, so they have too much leptin, and this is a vicious cycle. We will also look at markers of inflammation, such as plaque, hs-CRP, so high sensitive CRP, and then also homocysteine. So we're going to take a greater focus here and look at the real culprits, the real lipids that play a role with regards to cardiovascular considerations. So that's going to be the real LDL culprits. These are not proportional to LDL-C. Historically, we're just measuring LDL-C, and that's a good marker. LDL-C responds very well to traditional pharmacology. That's fine, but we can get better information when we look at these other biomarkers. Oxidized LDL. Oxidized LDL is a strong independent risk factor for cardiovascular disease. Again, the oxidized LDL is the lipid that contributes to atherosclerosis. So it initiates and progresses the pathogenesis of atherosclerosis. Consider this as oxidized. There's an inflammatory component. The oxidized LDL activates macrophages and other cells. So this continues the vicious cycle of atherosclerosis and endothelial inflammation. Oxidized LDL itself is associated with acute myocardial infarction, angina, metabolic syndrome, and hypothyroidism. This is not a talk about hypothyroidism, but we know there's a significant cohort of individuals with autoimmune hypothyroid, and that plays a role with regards to cardiovascular health. So hypothyroidism and cardiovascular health, we definitely want to address these individuals. And in individuals with autoimmune hypothyroid, we want to think about cardiovascular disease. All right. With regards to oxidized LDL, this is a lifestyle consideration. We know that trans fatty acids, can't believe it's not butter, things like that. Those are not healthy for us. They have contributed to the pathogenesis of dyslipidemia. Smoking is unfortunately a factor for this panel in general. So it could apply to basically all the biomarkers we're talking about today, based on the fact that cigarette smoke, nicotine is extremely chemically irritant to the endothelium. And it really doesn't play a role in human health in any regard besides adversely. Smoking of cigarettes is something to discontinue and anybody with any issues on this panel, as well as vaping. So the studies aren't necessarily here yet on vaping, but they will. We will see those studies. And we talked briefly about the nanoparticles of the plastic. With the vaping, the issue tends to be obviously the nicotine, but then the oils that are in there as well. And there may be some nanoparticle consideration. There may be some nanochemical considerations. There are some studies that they can affect DNA expression and things like that. So those studies will come who knows, probably in the next decade or so, and they will not be great for human health. Toxicant exposures play a role, and oxidative stress, of course, plays a role. In these individuals with elevated oxidized LDL, we want to think about antioxidant status, whether it's endogenous, dietary, or supplemental. You could also consider your patient's RBC glutathione level in those cases as well. The next factor is going to be small dense LDL. Remember, small dense LDL, it tells us in the name what's happening. It's tiny, it's heavy, it's considering to atherosclerosis. So therefore, it is a strong independent risk factor. It is extremely atherogenic. This cholesterol ester is depleted, so it's dropped off the other cholesterols, making it not large, buoyant, but small, tiny, and therefore it can readily penetrate the endothelium. It can carry less glutathione and vitamin E, so tocopherol, so it's not healthy, not antioxidant, and it oxidized due to that. And again, readily taken up by the macrophages, contributing to inflammation. This one is associated with elevated triglycerides and low HDL. So HDL is cardioprotective. We'll talk about that as well. For small dense LDL, you can consider exercise, weight reduction. Niacin is important right here. EPA and DHA rich fish oils, things like that, fibrates and statins all play a role. The next one we will look at is lipoprotein A. Lipoprotein A is, again, this is a genetic independent risk factor. It is associated with premature heart disease, thrombosis, and stroke. Again, it impedes the fibrinolytic activity via the stimulation of the secretion of tissue plasminogen activator inhibitor 1. Leptin does this as well. So basically, your body, with elevated lipoprotein A, the ability to break up clots is significantly altered, and there will be increased risk for clots and thrombotic events. Again, this is genetic, and I just want to reiterate, unfortunately, there's no good interventions here. You can slightly decrease it with diet and exercise. This is not. The one thing I will say is if you have really high levels of lipids and you decrease them dramatically, maybe you'll see a proportional decrease to lipoprotein A, but really there's not a lot of good solid interventions for this. There may be some roles for fish oil and niacin, and this may be a consideration for individuals to utilize multiple therapies at one, but again, a genetic component. Okay. The next ones are going to be the lipoproteins A1 and apolipoprotein B. Apolipoprotein A1 is on HDL. So this is going to be a part of those HDL particles that is going to be taking cholesterol from the periphery back to the liver. So recall, HDL is the quote unquote good cholesterol. And that's because HDL is responsible for basically cleaning up. It's like a garbage truck, goes to the periphery, takes all the cholesterol, brings it back to the liver. And that LDL is the bad cholesterol. It's not necessarily the bad cholesterol. Again, with these biomarkers, we just want to put them all together and think what's happening with regards to physiology. So LDL is not necessarily the bad cholesterol. What it's doing is it's taking cholesterol from the liver to the periphery. Where would we use cholesterol in the periphery? We're going to use that in the testes to make testosterone. We're going to use that in the adrenal glands to make cortisol. We're going to use that in the endothelium to patch up inflammation and damage that's been done. So it's not necessarily bad. It's like a firefighter going to put out the fire. It lets us know that something's occurring, but it itself isn't necessarily bad. So anyways, apolipoprotein A1, that's on the HDL particle. So this one is healthy. This is associated with decreasing inflammation. Now, apolipoprotein B1, B100, apolipoprotein B100 is on the non-HDL particles. So the chylomicron remnants, that's actually B48. That's a different one. B100 is on the intermediate density, the low density, the oxidized LDL, the small dense, and that genetic lipoprotein A. Every one of those lipids has one apolipoprotein attached to it. And so that's why people like understanding the number of apolipoprotein B, because it tells you how essentially direct measurement of lipid particles. All right. And then markers of inflammation do play a role here because inflammation and lipids are integrated with regards to cardiovascular disease. So the first marker that we're going to talk about is lipoprotein-associated phospholipase A2, abbreviated plaque. This is an enzymatic marker of the progression of cardiovascular disease, plaque instability, and the risk of cardiovascular events. So this is an enzyme that is a biomarker that tells us that those are occurring with regards to physiology. It's macrophage derived. It interacts with LDL and oxidized LDL. So if you want to look at all these markers together, so if somebody has elevated plaque and elevated oxidized LDL, that tells you that oxidized LDL is contributing to this pathogenesis, endothelial inflammation, atherosclerosis. So that's significant. If this is high in individuals, you want to talk about, again, the lifestyle considerations, diet, exercise, weight reduction. You want to look at our red blood cell fatty acid analysis, see if they have enough DHA and EPA, because that will help to decrease this marker. Check their HDL, consider CoQ10 supplementation, and then lower those other factors. The next one we're going to talk about is hyperglycemic excursions. Now, fasting glucose is an excellent marker, insulin is an excellent marker, and hemoglobin A1C are excellent markers. The other excellent marker that I would include in here is glycomark. So glycomark is serum 1,5-anhydroglucotol. This is this is secreted when the body has a hyperglycemic excursion, and it lasts in the system for 2 weeks. So if an individual had an episode of postprandial hyperglycemia within the past 2 weeks, you'll see that on the report. So it tells you how tightly the patient has glycemic variability. This is important because metabolic flexibility is really important with regards to cardiovascular health, longevity, and things of that nature. So serum 1,5-anhydroglucocol glycomark is correlated with cardiovascular disease and diabetic complications. And you can even see this in individuals that have a normal hemoglobin A1C, because remember, that's the glycosylated and glycosylated products. And this is telling you about the hyperglycemic excursion, so hyperglycemic control. You really want the body to be within normal limits there. So again, same thing we're saying here. Interestingly enough, this was more accurate than hemoglobin A1C and glucose in predicting mortality in patients that were hospitalized with COVID-19 with and without diabetes. So this glycemic control is a really important biomarker. So we have that included on the test as well. The next piece of information we have will be the adipokines. Leptin is a really important hormone. Leptin is the hormone that tells us when we're full. It tells us to stop eating. We see it that what happens is individuals become leptin resistant in a similar mechanism to insulin resistance. So the body has excess visceral adiposity and it signals excess leptin. And so then the signal doesn't work and people don't feel full after they're eating. So it's a vicious cycle because people are already overweight and they don't feel full after they're eating. This is associated with LPS endotoxemia. So again, inflammation, intestinal permeability, glucocorticoid drugs, alcohol abuse, hypothyroidism, and depression. Again, this leptin resistance leads to inflammation, cytokines, oxidative stress, and then you have what we talked about at the beginning of this conversation is accumulation of fatty liver. So this is a vicious cycle. This accelerates atherogenesis and is associated with myocardial infarction and stroke. Okay, so now we're going to go into some cases here. All right. So here we have the cardiometabolic profile. This is what we discussed. And the way that this is organized, if you look at the first 4 markers, this is the traditional the traditional lipid profile. Total cholesterol, triglycerides, HDL, and LDL. So that's the traditional markers. The next piece of information you have is the VLDL. That's an intermediate marker. Sometimes traditional primary care doctors are running that, sometimes they're not. So VLDL, so that's the very low density lipoprotein. And then we have the specific markers. The specific markers are non-HDL cholesterol, oxidized LDL, small dense LDL, and then you have the genetic lipoprotein A, and then you have a section about ratios. Ratios are important because depending on the numbers, you can lose information in the numbers unless you have the ratio. We'll see that in a case. So the ratios are going to be HDL to total cholesterol, LDL to HDL. You know that, you're familiar with that. Oxidized LDL to LDL. So that's really important because how much of the LDL is oxidized. The oxidized LDL is a really important factor because the oxidized LDL is the one that is specifically contributing to atherosclerosis. And then small dense LDL to LDL-C. So how much of that is that small dense atherogenic information? And then the balance between those apolipoprotein B and apolipoprotein A. The next piece of information is going to be those inflammatory markers. So plaque, which we discussed, homocysteine, which we're aware of, and then HS, high sensitive CRP. And then we're looking at the apolipoproteins, apolipoprotein A1, and then apolipoprotein B, the new kid on the block that everybody is interested in right now. The metabolic risk markers are included. So that's the next section. Okay. So now we're switching gears. We're talking about metabolic. Insulin, glucose, and glycomark. Those all go together. Then we're talking about leptin and adiponectin. Those are the adipokines housed in the fatty tissues. We talked about that. Housed in the visceral adiposity. The leptin to adiponectin ratio. And then we have the markers of kidney health here. So the markers of kidney health here are going to be cystatin C, creatinine, and GFR. Cystatin C is an excellent marker because this is very sensitive and specific to renal dysfunction prior to other biomarkers. Remember, renal dysfunction is associated with hypertension, but also we're talking about diabetes complications here as well. So the kidney health is on here as well. It's very important information. All right. So our first case is going to be a 51-year-old female. This woman is on a ketogenic diet and she's consuming eggs, lamb burgers, and cream primarily. Currently 142 pounds, 5'4", BMI is 24.37, so this is normal. Let's take a look at her profile here. So the first thing we're going to look at is the total cholesterol. Total cholesterol is an important piece of information, but it doesn't tell us all of the information. Now, I'm sure you've heard this ideology within the advocates of ketogenic and carnivore diet that it doesn't matter if the total cholesterol is fine. That's reasonable, but we want more information before we can actually tell what's happening with the lipids. And the other thing is, I will say sometimes people do need to be on these diets therapeutically. So in those individuals that do need to be on these therapeutic diets, run this profile and evaluate and tweak where you need to, okay? Total cholesterol is pretty high at 338, but let's see. Triglycerides. Triglycerides are really low at 51. Not really low. They're reasonable, but that's because the patient is not consuming carbohydrates. Triglycerides generally reflect carbohydrate consumption. So that looks great. HDL looks excellent at 88. Now here's where we get into the weeds. LDL is 240. So LDL is pretty high. But what about that LDL? How is it behaving? Let's find out. VLDL looks good, but the non-HDL cholesterol, remember, independent risk factor, very high at 250. Oxidized LDL, again, very high at 86. Small dense LDL, very high at 57. So of the LDLs that are there, they are oxidized, small dense. So these are the ones that are contributing to atherosclerosis. And we see that in the ratios. So let's jump down to the ratio. The ratios look okay. The LDL to HDL is okay. LDL to HDL-C is too high. The ratios are a little bit off. Okay. Now let's take a look at the next piece of information. The risk factors, inflammatory markers. The patient has enzyme plaque is there. So that is showing us that there is some formation of atherosclerosis, macrophages, inflammation in the endothelium. Same thing with the CRP is higher at 1.3. So there is some inflammation there. But then the next piece of information I'll take a look at here is that the apolipoprotein B is 174. That's really high. So we want to get this down. Insulin is low at 1.5. You will see this in your patients on the ketogenic and carnivore diets because ketones will decrease the insulin. Leptin is a little bit lower. It could be because the patient there's some medications, some psychotropic drugs and things like that decrease leptin. Some patients have genetically low leptin. What we're really looking for in the profile is elevated leptin. Okay, so let's take a look here. What are we going to do for this patient? The cholesterol is too high at 338, but more importantly, that non-HDL, that oxidized, that small dense are elevated. So we know that the patient has atherogenic factors there. The high plaque with the elevated CRP factors together. So we know those lipids are there. We know that plaque is there. And then we have the hsCRP, that inflammatory marker. Putting all those together is a significant risk. Additionally, the very high apolipoprotein B, significant red flag. So we want to put these all together. Just of note, the lower creatinine may be consistent with poor muscle mass. Sometimes with patients on ketogenic or carnivore diets, These patients aren't starting with a lot of muscle mass, so that's another factor. We talked about the low insulin. So for this patient, we want to reduce that metabolically active visceral abdominal fat. Again, fat that's lifestyle, exercise, and retest in 6 months. One thing I will note is the oxidized LDL and the ketogenic diets. You can address that via low carbohydrate vitamin C containing foods such as strawberries, bell peppers, broccoli, and cauliflower. We want to prioritize fats. The mono unsaturated oxidation resistant fats, that's going to be avocado oils and olive oil. Olive oil is so healthy for cardiovascular health. And some even postulate that olive oil is the smoking gun in the Mediterranean diet. The polyphenols in olive oil are very protective of cardiovascular health, and they do have positive outcomes. Of course, we want to decrease that intake of polyunsaturated fats. That's going to be the corns, the canola, those things. Eliminate that. All right. Our next case is a 51-year-old male on a standard American diet. This individual consumes fast food regularly for lunch and sometimes for dinner, drinks green tea instead of water because they think that's healthier. A jug of green tea that you can buy at the grocery store that's full of sugar. And the patient's on statin already to address the elevated cholesterol, but he really feels too tired for exercise. All right, let's see. Look at this profile. Very different profile. So what we see here, cholesterol, triglycerides, LDL, VLDL, non-HDL, oxidized LDL, those are all really within range. Now that makes sense because the patient is on a statin. That's appropriate. That's excellent information. The HDL is definitely too low, so we're thinking about inflammation. Moving further down the profile, just to note, the oxidized LDL to LDL is outside the reference range. So there's again an oxidation inflammation picture here. But then when we look at the plaque, homocysteine, and CRP, those are all very high. The next piece of information we have with the apolipoprotein is that protective apolipoprotein A1 is too low. Then we go further down. His insulin is definitely too high at 18.8. Glucose looks good, glycomark looks good, but then leptin is too high. So the patient is leptin resistant, adiponectin is too low. Okay. So with the inflammation here, so the low HDL and the low apolipoprotein 1, this is associated with the risk of cardiovascular disease. That's what we're talking about today. The considerations here, we need to increase omega-3 fatty acids, niacin, soluble fiber, very important. Decrease oxidative stress. Exercise is going to be important. So for these markers, 30 minutes of moderate intensity exercise most days of the week. The next piece of information we have is the elevated HSCRP. Again, you know this. Lifestyle changes, Mediterranean diet. In this case, it's 150 minutes of moderate exercise per week. So that would be the thing to do. Decrease oxidative stress. We talked about smoking, alcohol. Those things need to be alleviated. Again, add omega-3 fatty acids into the diet. Consider vitamin D deficiency, omega-3 fatty acids, HSCRP. All of these are interconnected. And then there is some information that statin therapy in individuals with elevated HSCRP and normal lipid levels will help reduce the risk of heart attack, stroke, and death. So that's good that he's on that on that statin. This individual has an elevated homocysteine, so we want to address that. I would run the methylation panel just to get more information. But of course, if we want to move homocysteine, we're going to move it through the methylation cycle, through the recycling of homocysteine back up to methionine. The cofactors there would be B12, folate, and then also we could push it down through transsulfuration to glutathione to support endogenous detoxification. I'd be curious if he has adequate glutathione status. I would guess maybe not. It could be low. So we'd want to push it down that way with B6 and consider glutathione status. So those, you could use supplements, you could use medications. For elevated homocysteine, there's many products on the market that will include B6, folate, B12, maybe TMG, maybe some betaine, all in one product. There's some medications of those available as well. And then you could use food, leafy greens, legumes, citrus, things like that, but probably in addition to. And this patient too with elevated homocysteine, I'd be thinking about kidney disease. The markers look good on the panel for that, but something to keep in the back of your mind. Hypothyroidism as well. Okay. I would definitely be curious of the patient's thyroid function. And then for the elevated leptin, you want to decrease the BMI. You want to consider the Mediterranean diet, lifestyle changes, decrease fructose consumption. That's really important across the board. And then address the insulin because the patient has elevated insulin resistance, leptin resistance, the same thing. Of note here, stress management is important because chronic stress, again, these lifestyle factors. The patient has low adiponectin. Remember, adiponectin is healthy. It is when it's too low, the patient is at risk for metabolic disorders, insulin resistance, type 2 diabetes, cardiovascular disease. Again, it's going to be those lifestyle modifications and improving insulin resistance, reducing body fat. A little more on the leptin to adiponectin ratio. So if we think about what's happening here, the leptin resistance is driven by the insulin, which is driven by the patient's diet, right? So the patient thinks that he's eating healthy. He's not eating healthy. He really doesn't have the proper information. So that's where really we can help the patients. So my heart goes out to patients because there's just not a lot of it. The information is so confusing out there. And then the other thing is my heart goes out to patients with elevated leptin because what happens is they have excess visceral adiposity. In the perfect world, what would happen is when you're full, the visceral adiposity, the leptin, the adipokines housed in the visceral adiposity would signal to the brain that you're full, stop eating. But in this patient, there's too much leptin, so that signaling does not work properly. And what happens is the patient doesn't feel full after he's eaten, and the brain actually interprets this as a starvation mode, and that leads to decreased movement and fatigue. So remember, he doesn't feel like exercising. He's tired. There's a neurological basis that's an endocrine basis as well associated with that. So we really want to help these patients and treat them with respect. So this is associated with increased inflammation, insulin resistance, and a higher risk of developing cardiovascular disease and diabetes mellitus. All right, third case here is a 66-year-old female. So this is a woman that had a history of 2 strokes within the past 24 months. This is resolved via a blood thinner, but she's still wondering, what can I do? BMI is 19, so lower within normal limits. So different individual, different presentation than we've been talking about. So what do we see here for this profile? Right off the bat, we can see that her lipids look healthy. Her cholesterol is 186, triglycerides are 59. Everything looks really good. HDL is 78, LDL is 96. That's really good. 78 to 96. I love that. But look at that LPA. That genetic LPA is extremely high at 78. Okay. So what do we see here for this patient? Inflammatory markers look good. The oxidized LDL, though, so just take a look at this. Oxidized LDL is 60, total LDL is 96. That ratio is high. So even though she has a small amount of lipids, what she has, there is some oxidation there. So we want to address that. Her insulin is a little bit lower. It's 1.8. With regards to the insulin value, there's some people that say 2 and 3 is optimal. I'll just retest this and look at it again, but I'm not going to worry too much about that. The leptin to adiponectin ratio is off, and that's just because her leptin is lower. You will see leptin lower in patients that are lower body mass. She does not have a lot of visceral adiposity. So for this patient, we want to address that oxidized LDL. Again, we are going to consider antioxidants, vitamin C, flavonoids, carotenoids, polyphenols. Polyphenols are so healthy. I will mention just real quick with polyphenols, since there's no recommended daily dose, but studies have shown that 1 to 2 grams per day are associated with decreased risk of chronic disease. So that's important. CoQ10 and glutathione are all going to be helpful here. Address sedentary lifestyle and stress and depression. For the genetic Lp(a), this is a genetic variation based on the LPA gene locus. Again, we know that it prevents thrombolytic activity. Excuse me. Yes. And so it is associated with elevated risk of clots. Unfortunately, for this patient, we're going to focus on the other factors that we can control because reducing LPA levels is not typically achieved through direct anticoagulant therapies. Niacin will help. There's some evidence for aspirin, although not specifically targeted at Lp(a). It can be utilized as a preventative measure. So right now, the patient is keeping her events under control. So this is definitely something to keep an eye on. And unfortunately, this is a genetic presentation. All right. Our last case is a 51-year-old female that eats healthy. BMI is 27.5, so that's higher. So I put the diet pops here because that's what happens. People are saying they eat healthy because they're consuming diet pop, or they're doing like a low fat something, or they're getting the whole grain bread. Yeah. So let's take a look. What do we see? So we can see right away the patient's actually not eating healthy. If we look at those triglycerides, really high at 276. Cholesterol is really high at 311. HDL is definitely too low at 41. So this is really low HDL. LDL cholesterol, VLDL, non-HDL, oxidized LDL, everything is really high. Okay, so we know the patient has a lot of cholesterol, a lot of triglycerides coming from that standard American diet. They're not eating healthy. And then we know that the lipids there are behaving in an oxidized manner, small dense LDL. Her LPA looks great, but then, so that's great genetics. She's really lucky here, but this is a lifestyle thing. So then we look at the ratios and they are all outside the reference interval. So let's skip down to the plaque. Plaque is really high at 270. So all of these are significant risk factors, significant risk red flags. So when we put it all together, we can see what the body's doing, and it is not healthy. HSCRP is really high at 2.7. Again, our apolipoprotein B is 194. Okay, so that's showing us that the lipoproteins that are there can be contributing to endothelial inflammation and atherosclerosis. Her leptin looks okay. Her adiponectin is definitely too low, so she needs to remediate with lifestyle strategies. Again, the hyperlipidemia is going to be addressed via lifestyle strategies, the Mediterranean diet. The Mediterranean diet is really going to be contrasting with the standard American diet for many reasons. One of the main things that you can do for that is you can have your patients consume food that is not processed. So the NOVA food classification system tells us that standard American diet is really ultra processed. The Mediterranean diet is eating whole foods. The NOVA food classification works like this. NOVA classification 1 is going to be a whole apple. So that's just a whole item. Classification 2 is when you slice it up and you have apple slices. Classification 3 is going to be apple sauce. Classification 4 is going to be apple juice. The standard American diet is on the classification 4, the Mediterranean diet, the class 1. So we want to move this patient to NOVA class 1. Also, we talked about olive oil is really important, polyphenols are really important, and soluble fiber is really important. All that's found in the Mediterranean diet, and all that is really really helpful for cardiovascular health. The other thing I will mention is the bottom of the Mediterranean diet. You may have seen this. The bottom of their food pyramid is meals with others. So sitting down, sharing meals with others, that does change our nervous system. That changes our expression of saliva and how we digest our food. So that makes a difference. Okay, we already know these, so I'm going to go through them fast. Omega-3 fatty acids for HDL, statins, and maybe red yeast rice for that LDL. Carbohydrate consumption, standard American diet needs to be addressed as related to the trigs, especially refined carbohydrates, high fructose corn syrup, those kinds of things. Elevated VLDL and non-HDL, lifestyle changes, sugar consumption. Again, we're talking about vitamin E, vitamin C, and CoQ10. Same thing with oxidized LDL. Again, vitamin E, vitamin C, flavonoids, carotenoids, polyphenols, CoQ10, glutathione, managing these lifestyle changes. And for the small dense LDL, you could consider statins, red yeast rice, niacin, omega-3 fatty acids. The plaque is too high for this patient. These are the same things that we said before. One addition is NSAID. In the interest of time, I'm going to speed up a little. Elevated HSCRP, you know this. They need to decrease smoking. They need to decrease alcohol consumption, decrease oxidative stress, increase omega-3 fatty acids. You could use statin therapy, especially in this patient, right? We saw those levels are really high. So you could consider some biomarkers. So the pharmaceuticals. The next one here is going to be apolipoprotein B100. So we talked about what that is a measurement of. So what can you do for this patient? Primarily address insulin resistance. That's important. You can consider there's some pharmacotherapy here. So statins. And then also there's a PCSK9 inhibitor drug which regulates the number of LDL receptors on the surface of the liver cell. So that brings more LDL into the liver, decreasing the LDL available in the periphery. Bile acid sequestrants will help as well, leading to increased excretion of cholesterol. So that's going to decrease the cholesterol. And then ezetimibe is a medication that can work to influence the absorption of cholesterol in the enterocytes. leading to decreased levels of LDL cholesterol. So those are medications that you may be of interest as well. Last but not least, the low adiponectin. We know that this is associated, again, type 2 diabetes, cardiovascular disease. The patient needs the lifestyle changes that we talked about, weight reduction, produce, fats, things like that. Okay? Address insulin resistance. All right. So we talked about the cardiometabolic profile. That's the profile. As you can see, it beautifully explains what's happening with regards to that individual's physiology. So that's an excellent profile. But you can always order individually. You can just order the oxidized LDL. That's an independent independent risk factor. You can order the cardiovascular profile because also you can order these as reorders. So if you just have one part of the profile that's outside the reference interval, you can order that. The metabolic profile is here. Again, the cardiometabolic is probably something you should do as a yearly for your patients, and then you could recheck 3 to 6 months to monitor. These biomarkers take some time to improve. And again, remember at the beginning of the conversation, we said the first sign of a myocardial infarction is a myocardial infarction. So people aren't going to necessarily feel better. They're not going to say, I feel better as my LDL is decreasing. But hopefully the lifestyle the lifestyle component of it, people will feel better, especially if we address nutrition, sleep, stress, things like that, exercise. Okay. But again, this is indicated for individuals with a family history of cardiovascular disease, visceral adiposity, insulin, diabetes, fatty liver, metabolic issues, things like that. Very simple venipuncture, fast turnaround time days. It is a fasting collection, 6 hours at least. You don't want to fast too long because that can decrease the leptin. So we saw in some of those. Additional considerations, the cardiovascular system is intricately connected to other systems. The microbiome, we're finding more and more research that there's a connection there. So GI 360 is important. Lead plays a role with cardiovascular burden. So toxic and essential elements is important. Hormones play a role. So comprehensive hormone profile, cortisol is important. Thyroid is important. So understanding that, HUMAP, hormonal metabolites. Again, thyroid is really important, especially in individuals with hypothyroid. I would address that. Vitamin D is important. And again, the methylation panel is important for the homocysteine component. One last thing I would just mention with this cardiometabolic lipid panel, if your patient is acutely ill, do not order this test at that time. Don't perform it at that time because it can influence the results. So we'd like to see it when the patients are in their well visits. Thank you so much.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.